Hi, this is Dr. Sargam, and today we are starting with our ophthalmology rapid revision day 1. So, the topic for today is uveal tract and its diseases. So, we know there are three parts of uveal tract: the iris, ciliary body, and the choroid. Ciliary body further has got two parts: pars plicata and your pars plana. So, here we have an MCQ: which one forms the aqueous humor of the eye? So, that is your pars plicata, that forms the aqueous humor of the eye. Then another MCQ here is which is the thinnest part of the iris. So like this is your iris, the central opening is referred to as the pupil, we all know. And this part of the iris that is attached to the ciliary body band, this part is known as the root of the iris. So this is the thinnest part. Now, what is the clinical significance? Here comes your MCQ. The clinical significance is that whenever trauma occurs, then this iris, it separates from its root. Okay. Now, how does it look like? So, if you look here at this picture, this part of iris has separated from its root, and this is what you call as iridodylisis or a D-shaped pupil. So this is very important exam question, and this was asked in Jan 2025 FMG exam, that what is this condition called. Then looking at the nerve supply, iris has got a sympathetic and a parasympathetic nerve supply. Basically, this is referring to the sphincter and the dilator pupillae. Okay, so the dilator pupillae gets its supply from the long ciliary nerve, and the sphincter pupillae gets its supply from the short ciliary nerve, which comes from your third cranial nerve. Then in the classification of uveitis, the one that is important according to your MCQ part is your anatomical or the Sun classification. Now, what does Sun stand for? Sun stands for the standardization of uveitis nomenclature. So it describes or it divides uveitis into three types depending on the site of involvement. So one is your anterior uveitis. We know anteriorly iris is present. So whenever you have any itis of either simply the iris with or without your ciliary body, that is your pars plicata involvement. Now any itis of the iris or the pars plicata is referred to as anterior uveitis. Then you have intermediate uveitis, in which there is itis or the inflammation of your pars plana. Then you have posterior uveitis, in which there is inflammation or the itis of choroid with or without your retinal involvement. Why? Because we know retina and choroid, they lie in close proximity with each other. Okay, so whenever your choroid is inflamed, your retina will be automatically involved. And whenever all three are involved, then what you call it as? You call it panuveitis. Now, what are the causes of anterior uveitis? So the most important is your seronegative arthropathy. This is characterized by mnemonic, which is pair. P stands for psoriasis, A stands for ankylosing spondylitis, I stands for your inflammatory bowel disease, and R stands for your Peters arthritis. Now, another cause of anterior uveitis, it can occur after trauma, surgery. Juvenile idiopathic arthritis, again you need to know it is of three types. When do we call juvenile idiopathic arthritis? As the name suggests, whenever there is any arthritis in a young male less than 16 years or more than or equal to 3 months of duration, then we call it JIA. Now it can either be pauciarticular when less than 5 joints of the body they are involved, or it can be polyarticular, more than 5 joints, or it can be Still's disease. Now, what is Still's disease? Still's disease is when you have systemic involvement. Okay. Now, the MCQ question here is, what is, which type of this arthritis, type of GIA is most commonly associated with your uveitis? So this polyarticular, this is the one that is most commonly associated with anterior uveitis. Okay, the other one is Fuchs heterochromic iridocyclitis. Now, just 2 points about Fuchs heterochromic iridocyclitis. As the name suggests, number one, it will have heterochromia. That means both the colors of your iris will be different. One will be lighter in shade and one will be darker in shade. Then you will have typical stellate KPs. And the third thing you need to know is the Amsler sign. So what is Amsler sign? It says that whenever you do any procedure such as gonioscopy, or you are doing any paracentesis, or whenever you are doing any tonometry, then because of the rupture of the iris vessels, what happens? There will be bleed in the angle of anterior chamber. So these are the only three things which you need to know for Fuchs heterochromic iridocyclitis. Then these are common points. So you should know what comes under, what are the diseases that come under seronegative arthropathy. You have this mnemonic pair. Then you should know about JIA, mainly the one that is associated with your anterior uveitis. And you should know these points about your Fuchs heterochromic iridocyclitis. Then what are the symptoms? Symptoms of anterior uveitis will be plain pain, blurring, photophobia and redness. Photophobia, it occurs due to ciliary muscle spasm. Then if we look at the signs of anterior uveitis from anterior to posterior, this is your cornea and your iris. These are the ciliary zonules, and here you have the lens. So looking at the signs, firstly we have got KPs, which are the keratic precipitate on the surface of cornea. Then another sign which we see here in the anterior chamber is the presence of anterior chamber cells. Third sign we see here is the presence of anterior chamber flare. Now we know that iris is very inflamed, it is sticky. So what will happen? It will stick, posterior surface of iris will stick onto the interior surface of the lens. What will it lead to? It will lead to the formation of what you call as posterior synecdoche. Now we know that this sticky iris will not stick 360-degree. Okay, so it will stick at some place and some place it will not be sticky. So when you try to dilate a patient who has posterior synecdoche, what will happen to the pupil? There will be irregular areas of dilatation and constriction. Okay. Now, what is this referred to as? This is referred to as festooned pupil. Okay, so these are the signs which you need to know for your anterior uveitis. Now let's look how do all of these they look. Then this is your hypopyon. What happens is whenever your anterior chamber cells, they are very much in number, what they do is they settle down by gravity. And what does it lead to? It leads to the formation of hypopyon. Here you can see cells in the anterior chamber. This is your typical picture of keratic precipitates. And then this is what you call as festooned pupil. This is your NEET PG 2024 question. Okay. Now, looking at other signs which we see on iris, we can see two types of nodules. The one present, this is the pupillary border. The ones present on the pupillary border are P for pupil, P for Pope's nodules. And the other ones that are present on the base or the root of the iris, B for base and B for Usaka's nodules. Okay. Then I have told you this is your cornea, this is your iris, here we have the lens. Now what happens is, because of the stickiness of the iris onto the anterior surface of the lens, aqueous humor will keep on accumulating behind the iris. Okay, so aqueous humor keeps on accumulating in the posterior chamber. What does it lead to? This will lead to forward bowing of the iris, which you call as iris Bombay formation. Now, what will it lead to? It will lead to what you call as seclusio pupillae. Okay, and this will what lead to? This will lead to secondary angle closure glaucoma. Sometimes what happens in severe inflammation, there is formation of a membrane in the area of the pupil. What is this phenomena called? This phenomena is referred to as occlusio pupillae. So these are two different phenomena. Now I've told you what is festoon pupil, how does it form. Then moving on to the management, we know any inflammation, any itis in the body, we have to give steroids. And along with that, I told you there is pain in anterior uveitis because of the ciliary spasm. So what will you do? You will give cycloplegics. What will they do? They will relieve the ciliary spasm. One very important thing, one very important MCQ which you should know is, in patients of JIA, chronic juvenile idiopathic arthritis, there are higher chances of band shaped keratopathy. Okay, this is one MCQ. Now, intermediate uveitis, it is not very important for the exam, but you need to know just 2-3 things. The symptoms are going to be floaters primarily, number one thing which you should know. Then you see these clumps of cells. Okay, so this is what you call as snowballs. And when these cells, they aggregate, then they form what you call as snow banking. As you can see here, there are multiple clumps present along the blood vessels. So this is what you call as snow banking. Management, intermediate uveitis, we know inflammation is in pars plana. What will we do? We will give, again, since it is itis, so you have to give steroids. Now, what are the routes, possible routes through which you can give steroids? You can give either direct steroids in the vitreous, which is called as intravitreal, or you can give steroids in periocular area, or you can give in the posterior subtenon injection. And yes, oral steroids also have a role. However, topical steroids, they are not preferred because they can't penetrate in so much amount into the vitreous. Now, next is your posterior uveitis. You just need to know 2-3 things important for your exam. They ask you, in which condition do we see candle wax dripping? It is your sarcoidosis. Now, to Three points about sarcoidosis. It has a systemic association which is called as uveal fever, or what you call as Hereford's syndrome. Now, what are the characteristics of Hereford syndrome? So, it includes, as the name suggests, uveitis, parotitis, and multiple cranial nerve palsy. Okay, now sarcoidosis typically it has got what you call as granulomatous type of uveitis. So, if the question is saying you are having conjunctival granuloma, scleritis, episcleritis, candle wax strippings, then your answer will be sarcoidosis. Now, what is candle wax stripping? Basically, along the blood vessel, you can see infiltrates like this. Okay. If you see here, there are multiple white infiltrates that are along the blood vessel. So, this is what you call as candle wax. You know, just like wax drips from a candle, same way the infiltrates, they are along the blood vessel. So, they are being compared to candle wax. Then is your tubercular. It is characteristic multifocal serpiginous choroiditis. If you ask me how does a patch of choroiditis look, तो पैच ऑफ कोरोइडाइटिस होता है, इट लुक्स एक्यूट स्टेज में तो इट लुक्स वाइट जस्ट लाइक दिस, एंड क्रॉनिक स्टेज में क्या होता है, उसको along with the central white periphery में there is blackish discoloration. Okay, center would be white and there is blackish discoloration in the periphery. Then if you look at AIDS, AIDS is primarily a microangiopathy just like your diabetic retinopathy. That means it involves the small blood vessels, the small arterioles, capillaries and the venules. So your signs will be cotton wool spots and hemorrhages. If you ask the most common, that will be the cotton wool spots. What are the opportunistic infection? The most common is your CMV. Then if they ask the most common carcinoma, that is your Kaposi sarcoma. Now, how does a patient present with CMV retinitis? In a patient with CMV retinitis, if you look here, there will be patches of necrosis which will look white and patches of hemorrhages. So, what do we call this appearance as? We call this appearance as pizza pie appearance. Just like when you eat a piece of pizza, you have both cheese and sauce. तो वो alternate सा करता है. That is why it is compared to pizza pie appearance, or your sauce and cheese type of retinopathy. Then you have varicella zoster virus or the herpes simplex virus, in which you can have acute retinal necrosis. Retina जब भी necrose होगा, it will have a white patch. Just remember this thing, any white patch on retina means area of retinal necrosis. Then toxoplasmosis, very important MCQ. They ask you कि toxoplasmosis की fundus appearance क्या होती है? It is headlight in fog. So your headlight is this. This is your patch of necrosis, and fog refers to the dense vitritis. One thing I forgot to tell you, CMV retinitis, it occurs when the CD4 plus cell count, it drops to less than 50 cells per microliter. Then you have Behçet's disease. It is HLA-B51 positive bilateral recurrent aphthous ulcers, genital ulcers, and your recurrent uveitis. Since you have जस्ट रिमेंबर वन थिंग, कोई भी सिस्टेमिक डिजीज होगी इट विल हैव बायलेटरल प्रेजेंटेशन, दोनों आईज में उसकी प्रेजेंटेशन होगी. इट इज नेवर गोइंग टू हैपन कि टीबी की वजह से अगर कोई प्रॉब्लम आ रही है इट विल जस्ट बी इन वन आई. टीबी पूरी बॉडी में है और वो दोनों आईज को इन्वॉल्व करेगी. ऐसा हो सकता है एक आई में ज्यादा मैनिफेस्टेशन हो और दूसरी में कम हो, बट बोथ विल बी. Then Vodka-Yanagi Harada, this is primarily for your NEET PG, not for the FMG students. तो इसमें क्या होता है? It is characterized by HLA D4 and D15 positivity. It is autoimmune in etiology. Autoimmune है तो कौन से cells को target करता है? This targets the melanocytes. तो इसमें क्या होता है? मेनली आपका posterior uveitis होता है, anterior uveitis is mild. One important sign in the interior part is your Segura sign, which is characterized by your perilimbal vitiligo. अब लिम्बस के अराउंड आपका डीपिगमेंटेशन का पैच होता है जिसको हम सिग्यूरा साइन कहते हैं. फंडस में डीपिगमेंटेशन होती है जिसको हम सनसेट ग्लो फंडस कहते हैं. एंड what are the syndrome है, since it is a syndrome, what are the other association? So primarily ये जो VKH है आपकी स्किन को इन्वॉल्व करती है, तो it leads to your poliosis and your alopecia and vitiligo. I may have told you sunset glow fundus and Segura sign. These are very characteristic. Baki ENT में if we see, then it leads to tinnitus and deafness. And if we look at central nervous system, it causes meningitis and encephalopathy. So this whole, when your skin ENT, when you have skin, ENT and eye manifestation along with the CNS manifestation, सब कुछ साथ होता है, then we call it as VKH syndrome. Now, most important for both FMG and NEET PG exam is your sympathetic ophthalmitis. Now, what is sympathetic ophthalmitis? Basically, whenever you have either trauma or penetrating injury in one eye. So basically, suppose मेरी right eye में trauma या penetrating injury हुई है, I will call that eye as my exciting eye. When this exciting eye, it leads to granulomatous panuveitis in my other eye. Now what will I call my other eye as? This will be my sympathizing eye. सो एक एक्साइटिंग आई हुई जिसमें आपका पेनिट्रेटिंग इंजरी हुई या ट्रॉमा हुआ, दूसरी आई आपकी हुई सिंपथाइजिंग आई. तो एक्साइटिंग आई में ट्रॉमा या पेनिट्रेटिंग इंजरी होने के बाद जब आपकी सिंपथाइजिंग आई में ग्रैनुलोमेटस पैन यूवियाइटिस होता है. ये दोनों वर्ड्स है ना, ये वर्ड्स ही बहुत इंपॉर्टेंट है कि ग्रैनुलोमेटस होता है और पैन यूवियाइटिस होता है. ये आपका प्रीवियस ईयर क्वेश्चन है जिसमें वो बार बार पूछते हैं कि इसमें किस टाइप का यूवियाइटिस होता है. दिस टाइप ऑफ यूवेटिस या दिस टाइप ऑफ मैनिफेस्टेशन इसको हम बोलते हैं सिंपथेटिक ऑप्थेल्माइटिस. इसमें HLA-A11 की पॉजिटिविटी होती है. मैक्सिमम केसेस आपके 2 वीक्स में हो जाते हैं. स्टार्ट मैनिफेस्टेशन आनी शुरू हो जाती है एंड इट कैन लास्ट अप टू 3 मंथ्स. मैक्सिमम में ये 1 ईयर के अंदर हो ही जाता है. नाउ व्हाट इज द अर्लीस्ट साइट ऑफ इन्वॉल्वमेंट? दैट इज योर सिलियरी बॉडी. नाउ वी नो सिलरी बॉडी पीछे होती है, उसके आगे हमारा लेंस होता है, राइट? ऐसे साइड में पड़ी होती है सिलरी बॉडी. साइन हमें सबसे पहले क्या दिखेगा? रेट्रोलेंटल फ्लेयर. दैट मीन्स फ्लेयर बिहाइंड योर लेंस. अर्लिएस्ट साइन वुड बी योर रेट्रोलेंटल फ्लेयर. एंड सिम्टम आपका क्या होगा? बिकॉज सिलरी बॉडी इन्वॉल्व है, सो देयर विल बी स्पाज्म ऑफ सिलरी मसल्स एंड पेशेंट विल हैव फोटोफोबिया. नाउ पोस्टीरियर सेगमेंट में अगर हम मैनिफेस्टेशन देखें तो क्या है? तो यू हैव दीज येलो white nodules that are located deep to the retina. Now what are these yellow white nodules called as? These are called as Galen Fuchs nodule. Now if you ask me the management में क्या रहता है? प्रिवेंशन के लिए remove the remove, or you can say enucleate the exciting eye within 2 weeks of injury. And how will you manage it? Management involves giving steroids, high dose via all routes. Now that means आप ओरल भी दे दो, टॉपिकल भी दे दो, पेरीबल्बर भी लगा दो, आईवी भी दे दो, जितने रूट से आप दे सकते दो। ठीक है। आप मैनेजमेंट कब करोगे? जब आपका सिंपथेटिक ऑप्थेल्माइटिस हैज सेट इन, जब आपका स्टार्ट हो गया तो आपको स्टेरॉइड देने पड़ेंगे। और अगर आपको प्रोफाइल एक्सेस करनी है, यू आर सस्पेक्टिंग कि हो सकता है, देन इन्यूक्लिएट द एक्साइटिंग आई। अगर देर आर सम पेशेंट्स हु कांट टॉलरेट स्टेरॉइड्स और आर किडनी के पेशेंट्स, उसमें हम क्या कर सकते हैं? वी कैन गिव स्टेरॉइड sparing agents. Now, what are these? These are either your immunomodulators or these are your biologic. So, this is all you need to know of ophthalmitis for your exam. If you ask me सबसे important part क्या है इस उस स्लाइड में, नंबर 1 इज योर किस टाइप का हमारा यूवियाइटिस होता है, साइट ऑफ इन्वॉल्वमेंट क्या है, HLA पॉजिटिविटी क्या है, कुछ में क्या है, और हमारा मैनेजमेंट क्या है. सो दिस इज ऑल दैट इज इम्पोर्टेंट. Then the last topic in uveitis is your endophthalmitis. So what is the meaning of endo? Endo मतलब आँख के अंदर. So there is itis or the inflammation of the interior and posterior cavities of the eyeball. Basically, whenever you have pus in the anterior chamber or associated with the inflammation in the vitreous, then you will vitreous cavity, then you will call it as endophthalmitis. Okay, now what are the risk factors? Risk factors are again any penetrating trauma, any perforated corneal ulcer, any prior intraocular surgery with a patient who has poorly controlled डायबिटीज मेलाइटिस. ओके, सो बेसिकली जब भी या तो आपका पेशेंट इम्यूनो कॉम्प्रोमाइज्ड हो या पेशेंट का कोई भी तरह का, व्हाट कैन यू कॉल दीज थिंग्स एज? यू कैन कॉल दीज टू एज ओपन ग्लोब इंजरी टाइप का. बेसिकली आपका या तो ओपन ग्लोब इंजरी हो जाए, या कोई कॉर्नियल अल्सर फट जाए, या आपकी कोई इंट्राऑक्युलर सर्जरी हो, so that predisposes the patient endophthalmitis. Now, how will the patient present? So symptoms will be pain, redness, and loss of vision. Signs I have told you. Signs will be your hypopyon and your vitritis. Now, how will we see vitritis? Vitritis is seen on B scan. Now, what is B scan? B scan is the ultrasound of the posterior segment of the eyeball. Now, if you ask me what is the management of endophthalmitis, the management of endophthalmitis, if we talk about the prophylaxis, then they say that the single most important thing what you can do to prevent endophthalmitis is your instillation 5% povidone iodine in the conjunctival fornix 3 to 5 minutes prior to surgery. Another thing you can do is pre-operative antibiotic. And the third important thing you can do is intracameral, means you are injecting directly into the interior chamber. So you can also give these intracameral antibiotics. Now, once endophthalmitis has set in, what is the management? So whenever a patient with endophthalmitis comes to the OPD, you have to, once you confirm the diagnosis, then what will you do? You will give a shot of intravitreal injections. Now, what intravitreal injections they are given? They are given both antibiotic and antifungal injections are given. अभी एंटीबायोटिक में कौन कौन से होते हैं? वी हैव वैंकोमाइसिन, वी हैव सेफ्टाजिडीम, देन वी हैव अमीकासिन. Which antibiotic is contraindicated? Gentamicin is contraindicated intravitreally. Why? Because it causes your macular ischemia. देन एंटीफंगल की बात करें तो एंटीफंगल हम कौन कौन सा दे सकते हैं? वी कैन गिव ओरिकोनाजोल एंड वी कैन गिव एम्फोटेरेसिन बी. सो व्हाट विल डू? विल गिव इमीडिएट इंट्राविट्रल इंजेक्शन. इंट्राविट्रल इंजेक्शन देने के बाद देन वी लुक आफ्टर 24 आवर्स. अभी 24 आवर्स के बाद हमें क्या हो सकता है? या तो पेशेंट को इम्प्रूवमेंट हो सकती है. ठीक है, इम्प्रूवमेंट है तो हम पेशेंट को एक और शॉट दे देंगे इंट्राविट्रल का. And if there is no improvement, then what will you do? You will do pars plana vitrectomy. That means हम लोग विट्रियस में पार्स प्लेना रूट के थ्रू जाएंगे. पार्स प्लेना जहाँ पे सिलरी बॉडी का होता है वहाँ से हम पोर्ट से अपना मशीन को एंटर करेंगे विट्रेक्टमी कटर को और हम पूरे विट्रियस को विल ईट अप द विट्रियस. दैट इज योर पार्स प्लेना विट्रेक्टमी. ओके, नाउ व्हाट इज tan ophthalmitis? Tan ophthalmitis, whenever in a patient of endophthalmitis you start seeing the corneal or the scleral involvement, then you call it as pan ophthalmitis. Okay, now if we talk about the management of panophthalmitis, since the infection has already set in and it has involved all the layers, you have to remove the eye. The management will be enucleation. Sorry, the management here is the evisceration. So evisceration can either be your scleral frill evisceration or it can be simple evisceration. So what are we doing in evisceration? We are basically scooping out the contents of the eyeball and we are leaving a part of the sclera behind and we are suturing that part of the sclera. Okay, now another thing, आपको endophthalmitis के causes पता होने चाहिए. Causes most common is your staph aureus. Acute cases में staph epidermidis. Just remember one thing, endophthalmitis में infection का क्या source होगा? आँख के आसपास. So what do we have? We have staph there. लेट ऑनसेट में हमेशा हमारा फंगल होता है और एंडिया कैप्सुलोटमी के बाद वी हैव कैंडिडा. दिस इज इम्पॉर्टेंट प्राइमरली फॉर योर नीट पीजी, नॉट फॉर योर एफएमजी. एफएमजी के लिए आपको प्रेजेंटेशन पता होनी चाहिए, मैनेजमेंट पता होनी चाहिए. हमारा फर्स्ट लाइन इंट्राविट्रल रहता है. इंट्राविट्रल से इंप्रूवमेंट आया तो एक और शॉट दे दो इंट्राविट्रल का, नहीं आया तो पास प्लेना विट्रेक्टमी कर दो. एंडोफ्थेल्माइटिस के पेशेंट में अगर कॉर्नियल या स्क्लेरल इन्वॉल्वमेंट है, दैट मीन्स आपका पैनोफ्थेल्माइटिस सेट इन करके पैनोफ्थेल्माइटिस के लिए आप मैनेजमेंट में करते हो evisceration. So this was all about uveitis and our tomorrow's topic will be on retina. So if you all like the video, you can share it with your friends and you can subscribe to my channel, those who haven't subscribed. And if you have any doubt, you can pour down in the comments below. Thank you.